Even though IVF has been around now for over 40 years, the number of myths and misconceptions which surround it are remarkable. And this is true not just for patients, but sometimes for doctors and journalists and gynecologists as well. One of the commonest problems is people don't seem to understand the difference between an embryo transfer and embryo implantation. And let me spend some time explaining this. And you want to find out more? Watch the entire video. I'm Dr. Malpani. I'm an IVF specialist, and what I try to do is make sure that patients have realistic expectations of what IVF can do for them. So, an embryo transfer is a straightforward medical procedure. It's the mechanical act of using a long plastic hollow tube called a catheter, which the embryologist loads in the IVF lab with the embryo, preferably just one embryo. This embryo is in culture medium, and then brings this catheter with the embryo in it to the doctor who's in the operation theater. And the doctor then puts this embryo transfer catheter with the embryo inside your uterus, preferably under ultrasound guidance so they can see what they're happening, and then injects this embryo into your uterus. This mechanical procedure is called an embryo transfer. It's done under ultrasound guidance because we can actually see the catheter go inside the uterine cavity, and we can see a flash. Now, you can't see an embryo on the ultrasound. Remember, embryos are microscopic. Only the embryologist can see them in the IVF lab. Where does this flash come from? When the embryologist loads the embryos in the embryo transfer catheter, he puts them in culture medium, surrounded or sandwiched between air bubbles. And it's the air bubble which we're seeing, which tells us that yes, this catheter is in the right place, the embryo was mechanically deposited in the right place. And that's end of the procedure. Which means doctors can do embryo transfers. But once we put the embryo back in the uterus, then whether that embryo will implant or not is not in a doctor's hands, or in your hands for that matter. Sure, we will give you all the appropriate medication, which includes estrogen and progesterone for luteal phase support. But the reality is an in utero biological process of implantation is not something which any doctor can control. And part of the problem is it is an inefficient process. And that's the reason why every fertile couple doesn't get pregnant every month they have sex. Because the woman ovulates, he has sex, he's got good sperms. The sperms and eggs must be meeting, but she doesn't get pregnant. And she doesn't get pregnant because even though the sperms reach the eggs in the fallopian tube and most early fertilize and form an embryo, that embryo does not implant. This is true in vivo, which is in the bedroom, in nature. And that's nature's inefficiency. And obviously that same inefficiency is going to be true even after IVF, because whether the embryo is made in the bedroom by having sex or it was made in the IVF lab by the embryologist by doing IVF or ICSI doesn't make any difference. The basic steps of implantation remain exactly the same, and that's not something which we can control. And part of the problem is implantation is still a black box area. We understand some of the process, but there's a lot of it, quite frankly, we don't. So for example, when we put the embryo back inside the uterus, there is a very complex dance of molecular signals between the embryo and the uterus lining or the endometrium so that it latches on and then sticks. Some of the processes we understand. So for example, it's got to come close to the endometrium, what's called apposition. It's then got to stick, what's called adherence. And then it's got to invade, what's called invasion. Fancy words, but common sense. You understand what I'm saying. Got to stick. And more importantly, it's got to invade so that it establishes a blood supply, so that this embryo continues to grow based on the nutrition provided by the mother's circulatory system, because that's the only source of nutrition that embryo has. And because we can't control any of these things, that's why the pregnancy rate after a good embryo transfer, and when I say good means it was easy, there were no complications, top quality embryo, is not 100%. And that's just something we can't do much about. We need to live with that inefficiency, which is very frustrating for patients and for doctors, because the doctor is happy, hey, the patient's happy, here's your top quality blastocyst, here's your picture, best of luck. And then when it doesn't work, of course, patients go to pieces. Some important things. You need to make sure that your embryo transfer was in fact, in inverted commas, a good embryo transfer. And how do you do that? Ask the doctor for proof. You need documentation that the embryos which are transferred were top quality blastocysts, so you must have photographs. And it's a great idea that most good doctors will actually show you the transfer on the ultrasound screen, so you can actually see the catheter go into your uterine cavity and the flash, so that at least you know that the embryo were top quality and the mechanical process itself was straightforward enough. After that, honestly, we have no control except praying, which always helps. If you have any questions or you need more clarifications, please feel free to talk to me. You can email me. Our website is www.drmalpani.com. Free service we offer. We have a free second opinion form. Everything you say is personal and confidential and comes to me, and I answer all my emails myself. We look forward to helping you to have a baby. See you online.